welcome to Talk Trillium, Partnering for Patients. I'm Patty Cochran, Senior Vice President and Chief Innovation Officer at Trillium Health Partners, which has 3 sites, the Credit Valley Hospital, the Mississauga Hospital, and the Queensway Health Center. Today we're talking about how Trillium Health Partners is working towards creating a new kind of healthcare for a healthier community, and today's segment is really going to focus on chronic disease management. But first, I'm really privileged to welcome our guest, Dr. Dante Morra. Dr. Morra is our Chief of Staff for Trillium Health Partners. And before we start talking about chronic disease, Dante, tell me a little bit more about why Trillium Health Partners, why be the Chief of Staff for Trillium Health Partners?
Well, Patty, first of all, thanks so much for having me here. And I'm always really excited to talk about healthcare in Mississauga and Trillium Health Partners. And I'll start off by saying the reason why I'm here is I actually think that Trillium Health Partners in the West, in this region, is one of the most important places in healthcare in Canada and even internationally. And so my background is I came from the Toronto General Hospital and University Health Network, where I've had a variety of different leadership positions at a local and regional level. And I'm an internist, so I take care of patients with chronic disease. I'm also appointed to the Rotman School of Business. And I teach strategy and operations and have run a research center that looks at change and innovation in healthcare. And so I see Trillium Health Partners, the West, and the opportunity to really transform the healthcare system and to have a real big impact on the healthcare system, but also on this community, because this is an incredibly special community for me. I was born at the Mississauga Hospital. I grew up in the West, and I call this home. And so the opportunity to work and to lead in healthcare, which is my passion in the area that I care so much about, was just a no-brainer for me.
We're so privileged to have your leadership here at Trillium Health Partners, Dante. So my next question is really around chronic disease. Can you explain to us what is chronic disease?
So when most people think about healthcare, they think about what we call episodic treatment. And really our healthcare system was designed in a post-Second World War model around episodic care. So what I mean by that is when people think about healthcare, they'll think about, okay, well, I have an infection, so I'll go to my doctor and I'll get an antibiotic. Or I have appendicitis, so I have a problem and I go to the hospital and I get my appendix taken out and I'm better. So when we think about healthcare, we think about someone being sick and then someone getting fixed and then they're well. But what the reality is that because of the advances of healthcare and the success of it, what we have now is about 5% of the population, so if you think just 5% of the population using up about 66% of the resources. And the reason is because they have a disease in an organ, either their lungs, their heart, or both, or their brain, and they don't actually ever get cured of that. It goes on and on and on. And so our system has been designed for episodic care, but the vast majority of healthcare that's actually delivered is around chronic disease. And really what that is a illness that isn't actually cured, but it's managed over time. And this has been a fundamental shift in the delivery of healthcare really over the last 20 years.
So we've been experiencing a lot of growth and I'd say a lot of aging in our community. And when you speak about chronic disease, you're mentioning that we're seeing more and more of it. Yeah. What impact does that have then on our organization?
Well, I think there's probably 2 major impacts. The first is as you have an aging population and more chronic disease, there's just more demand. There's more demand on our emergency rooms, on our inpatient and surgical platform. There's just more people needing more care. And it's not because that the population is growing very dynamically out here in the West, but as people age, they get more chronic disease and their use of resources higher. So there's more demand on the system. But the second thing is that the demand is different. So if the system is designed to cure someone, to have one interaction with that person and then they go away, when you have somebody who's coming back to the hospital multiple points and they need multiple different providers. So if they have heart disease and they have dementia or they have liver disease, but it's all together, you actually, the way the system is delivered has to change. And so it's more demand, but it's also a demand in a different way. And so what we need to do is help transform and deal with that demand and expand, but also change the way that we're delivering our care.
So if I were to think about it, if I were the patient and living with a chronic disease, you're saying that I'm going to have this disease over a longer period of time because it doesn't actually ever get cured, but it may also mean that I'm going to go from hospital back to the community, back to my family doctor. So I'm going to be under the care of multiple people over a period of time. How does that all get coordinated?
So I think that's a really nice way of putting it, is that you don't just have one interaction. There's multiple different providers of nurses, of primary care, family doctors, specialists. And really, when we have one chronic disease, if you just have a heart problem, we actually do a pretty good job. But if, let's say you have a heart problem and you have a lung problem and you also are getting chemotherapy for cancer, and this is actually the reality, is most people over the age of 65 actually have 2 or more chronic diseases. And so that coordination of care is something that's lacking within the system. And one of our real strategic visions around a new kind of healthcare for a healthier community is we want to improve health in the community and help coordinate and redesign how we deliver care, so that we can have a model where you would see all your specialists together. There'd be coordination with your family doctor and a whole system of care to take care of you.
That's great. Now, you did talk about chronic disease, and you mentioned something about lungs and hearts. Yeah. But what are some of the more common chronic diseases that are out there?
Yeah. So I think if you think about just body parts, so and you just go to your major body parts. So the most common ones there's heart disease. And that's heart failure, where your heart is having difficulty pumping all the blood around, and that's often because of heart attacks or coronary disease, where you're not getting enough blood flow to the heart. That's a very common one. Then there's something called chronic obstructive pulmonary disease, or COPD, where your lungs are sort of not as strong over time. And there's a lot of causes of these. There's liver disease or cirrhosis. Diabetes is a major cause. We have dementia, of which Alzheimer's disease is one of the causes of it. And even bone disorders like osteoporosis and arthritis. So really, if you really think of it and you go through all your major organs and you almost do an anatomy lesson through, as you age and as you have insults to these organs, they can have difficulty. Now, with modern medicine and with good care, what used to actually kill you 20, 30 years ago, you'd have a heart attack and you die. Now we provide life-saving treatment, but that causes that heart to have a 30-year treatment rather than to have the problem when they first came in. So really, chronic disease is actually the success of modern medicine. But now, as we solve one problem, we actually need to turn our attention to the coordination of dealing with all these different body parts as people age.
So do you have any tips for us on how to stay healthy and well in spite of all of these chronic diseases? And as you mentioned, it is the success of medicine. I think we are living longer, and the 60-year-olds of today are really the 40-year-olds of yesterday. Yeah. So any tips for us on keeping well?
Well, I think, the things that have been shown over time to really help people and allow them to have long and healthy and productive lives are the simple things, but they're the hard things to do. So, don't smoke, don't overeat, and keep your weight at a good level. Activity is very important, and one of the things that people often don't think about is social contact. So what we're finding is, particularly with mental illness, and with all the chronic diseases, is the more people who are healthy around you, the more active you are, the more you're connected into your community, the more people that you're helping, and the more purpose that you have is actually a powerful piece. So I think it's, I know those are a lot of very simple things, but those are the things that really, being active, not smoking, not drinking too much, keeping social contact and maintaining your lifestyle. Those are really the key things. And then the second piece is having good contact with your primary care provider and having a relationship with your family doctor who's looking at the holistic part of you and ensuring that your care is coordinated, that you're getting prevention along the way, you're getting checked for high blood pressure and diabetes and all these things so that you can prevent them, and if they do start, to treat them very early on. Because it's always easier to treat a problem earlier rather than later.
So it sounds to me like we have things that we should all be doing, keeping our weight, being active. But the third thing that you mentioned really was around making sure that we have a primary care doctor, because they can run prevention and screen us for some of these chronic diseases.
Yeah. And I would say maybe one other thing, and that is, when you're in the system, you have to be your own advocate. You have to actually ensure you know what your medications are. You need to ask those questions when you're at difficult appointments. Make sure that you have someone there beside you, because when you're getting health information, it's often overwhelming. So I think taking care of yourself, ensuring you have a good primary care, ensuring you're getting help navigating the system, and you're taking care of yourself almost like a project, I think is really important as well, particularly as you have different chronic diseases and you have multiple different medications.
We're going to hear a little bit more around chronic diseases, specifically chronic kidney disease, COPD, and diabetes at the rest of the show. In the last minute, what about the role of internet and Google on information? Is it a good source of information?
Yeah, so I believe patients who are activated and informed and involved in their care, it's the best way to provide healthcare. And I know at Trillium Health Partners we are committed to patient engagement, and that's everywhere from having patients at the board level, at the decision-making table operationally, and right through our organization. And I believe it's the same when you're with a patient. So I think there are lots of sites that have good information. You can ask your physician about those, take that information, have a dialogue, and I believe medicine in a way is changing. We're becoming educators together, and there's a lot of information out there. And I would usually say is don't act upon that information until you have that conversation, but arm yourself and be informative.
You know, it's a real privilege to have you on the show, but more importantly, to be at the helm as Chief of Staff at Trillium Health Partners. Thank you so much for joining us today. Dante, it was really a privilege.
It was wonderful to be here, Patty. Thanks so much for having me.
Yeah, thank you. Back to Talk Trillium. Today we're talking about chronic disease, and we're going to focus this segment on chronic kidney disease. Joining me are three guests: Dr. David Perkins, he's the medical director of our regional CKD program; Sandy Beckett, who's our director of medical outpatients as well as our regional CKD program; and Ron Miles, most importantly, he's our patient today who's been living with chronic kidney disease. Before we start, David, maybe you could talk to us. What is chronic kidney disease?
Well, as many people may know, the kidneys are very important for cleaning the blood of waste and excess water, and they work 24 hours a day doing this. And the kidneys are essential, just like the hearts and lungs. Now, chronic kidney disease is when the kidneys are damaged and the functions reduced for a period of at least 3 months. And about 1 in 10 Canadians has chronic kidney disease. And we need to take chronic kidney disease seriously, because without our kidneys, people can't survive. In fact, when kidney function drops below 10% of normal, a person needs to have dialysis or a kidney transplant to stay alive and stay well.
And I understand that it's not just chronic kidney disease that patients have. Often they have other chronic conditions. Is that true?
Absolutely. In fact, 2 of the most common risk factors for kidney disease are diabetes and high blood pressure, both of which themselves are chronic diseases. In addition, people who have cardiovascular disease and have a weak heart, they often develop heart failure where the heart pump is very weak, and this makes the kidney function weak as well. Yeah.
Now, Sandy, you experience and see patients going through many stages of chronic kidney disease. When they're first diagnosed with this disease, what are the common questions or concerns that get asked of you?
Yeah, patients have a lot of questions, and primarily they just want to know, how is this going to change my life? You know, will I still be able to work or go to school? Can I still travel? How is it going to impact my family? Is there a cure? Is there a pill I can take to fix this? A lot of patients have questions about transplant, and they've heard. So our team tries to address all of those questions over time, because patients can only take in so much information at one time, and provide them with the right information.
Great, thanks. So Ron, you are a patient. You've been surviving with chronic kidney disease for how many years now?
8 years.
8 years. So tell us a little bit about how you first got diagnosed with this disease.
It was a bolt out of the blue. I went for a physical to my general practitioner, and there's a routine blood pressure, and I failed that miserably at 180 over 150.
Wow.
And the little routine urine test you do with your family doctor that just everyone does, well, mine came back all colors of the rainbow, which she'd never seen before. So you need to see a nephrologist. I'm thinking, all right, 6 months from now. No, it was 3 weeks later, sitting with a nephrologist. Well, you need a biopsy. Again, I'm thinking 3 to 6 months. No, 3 weeks later, I'm getting my biopsy. So in 8 weeks, my world went from everything is good to you have chronic kidney disease. You're going to be joining the Credit Valley renal program, and down the road, you're going to need dialysis and a transplant. With my particular illness, it has only one long-term outcome. So it was trying to get my head wrapped around my world suddenly got turned upside down for myself, my wife, and my son.
So in 8 years now, how would you say it's affected your lifestyle? Has it had a major impact?
It has an impact because initially I didn't need treatment. It was just a question of trying to slow the illness. So it's changes to your fluid intake, changes to your diet, and just the slow progression of the disease, you start gradually feeling less well. And then you get to a point where it's like, all right, I'm now at a stage where I'm going to need treatment. And is it going to be in-center dialysis, hemodialysis? Is it going to be at-home peritoneal dialysis? Is it going to be at-home hemo? I don't like blood. I don't like needles. So peritoneal dialysis was the easy choice at the time. And also, my dad had renal disease, so I'd seen in-center hemo. So I wanted to do at home. So it was, so doing peritoneal, which changes your world again because it's more restrictive than when you're pre-dialysis.
So sticking with the pre-dialysis phase, just Sandy, what are some of the tips that patients can use to keep that pre-dialysis stage as long as possible?
We have, when patients come to our pre-dialysis clinic, we call it KCC, the Kidney Care Clinic, we have a team to meet with that patient and provide them with all that advice. So we have registered dietitians. As Ron said, you know, your fluid intake and what you eat is critical, so we provide all of that education. And we have pharmacists who can talk to you about the medications you're on, not just for your kidney disease, but other medications you might be on, and how they interact. And also, people like to take supplements and vitamins and holistic medications, and it's important to look at how all those are interacting. So they'll meet with all our team members, the physicians, the nurses, and do everything that we can to help slow that progression.
So Dr. Perkins, it sounds to me like there's many people involved in the care and management for the patient. Sounds like there's a clinic with some multidisciplinary people. Can you talk a little bit more about the role of coordinating all of that care and the link with the family doctor?
Certainly. I believe that the patient should certainly be seeing their family doctors regularly, because I believe the family doctor is the central hub who's familiar with all of the patient's health issues and who can help coordinate things. And the family doctor will be communicating with the various specialists, perhaps us as the kidney doctors, but also other specialists managing diabetes as an example. So that's very important, that communication is very important. I think also that we try to encourage patients to have an open and honest communication with the healthcare team, and where they can bring all their questions and concerns so that we can try to develop solutions together and help educate them so that they can cope better with their illness.
So it sounds, Ron, like your disease progressed and then you had a choice to make around the type of dialysis. What type of dialysis are you on now?
I'm now actually doing hemodialysis, and I'm doing it at home.
Wow, at home. So tell us a little bit, maybe Sandy or Dr. Perkins, what is dialysis?
I'll explain it from the layman's point of view. As Dave said earlier, the kidneys are there to clean your blood and control the volume of fluid in our bodies. And when our kidneys can't do that, dialysis does that role. So hemodialysis, as Ron is doing in the home or we do in center, uses a machine that has a filter called a dialyzer that kind of cleans the blood for you. The other type that Ron alluded to is the peritoneal dialysis that can be done in the home, and that uses your abdominal cavity to clean the blood through exchanges with special fluid. So there are all different types, and they can be done in the home or in center. We always encourage home first, just because the outcomes are so much better for patients. But your individual needs would be addressed by your physician in consultation with you and your family and the nurses and the team.
So Ron, talk to us a little bit about home hemodialysis.
Right, so home hemo has been the best phase of my illness. I mean, in terms of how I feel, how I function day to day, there's no comparison. I've done peritoneal, I've done in-center hemo, and I've done it at home. And home hemo is, once you experience it for a number of months, your body adapts to it. It's by far the closest I've come to feeling healthy since my original diagnosis.
Wow, that's quite a statement.
And what's so terrific about it is we're trying to replicate what the natural kidneys are doing, which is working 24 hours a day. And home hemodialysis allows us to provide more dialysis, more cleaning of the blood to the patient than they would otherwise receive if they were having dialysis in center at the hospital.
Yeah, so looking at you, Ron, you'd never know that you actually have a chronic disease.
Had you seen me 2.5 years ago, it would have been very obvious. I mean, like the difference. Like people who haven't seen me for a period of time comment on the change in my appearance.
Really?
Because 2.5 years, I really did look profoundly ill.
So what does home hemodialysis mean for you? How often do you have to hook up to your machine? Where is it located in your home? What kind of supports do you get?
So, I mean, at home, we actually have a spare bedroom, and I've set it up in there so I can do my treatments in there. Because during the night, you can get alarms. There's a light, so it can be disturbing to a spouse. So typically, on my treatment nights, I'm in my treatment room, hooked up to the machine. You have to set the machine up yourself, so you train through the program how to set your machine up, how to prime the machine, how to do your own needling. Needling was, for most patients, the biggest challenge is how do I get needles in? And in my case, I tended to faint with needles, so I did 3 months of hypnotherapy to get over that fear.
Did you really? Hypnotherapy? And did the center, I know, did the center help organize that?
So as actually one of the social worker had the suggestion, she had a name as a reference that started that ball rolling to get me in there. And what's interesting now that I'm doing my own needling, when I go in center for like a test, I still insist in putting my own needles in. I could never imagine going back to having another practitioner do my needling. I much sooner control it myself.
Great.
We really try to pride ourselves on being very patient-centered and considering the barriers that each patient has to performing dialysis at home and trying to help them overcome them one by one, just
That's
like
great.
you'd heard from Ron.
Now, I understand there's a new regional nephrology clinic that just recently opened. Do you want to talk a little bit about that? What does it mean for patients?
Sure. The regional nephrology clinic is located at Credit Valley Hospital, and it's intended to be the single point of entry for all patients in the region who have any type of kidney-related condition or illness that needs treatment and assessment. And so this provides a single location for all patients to come to where they can have their disease properly managed by a team of healthcare providers.
Great. So I would imagine wait times are shorter.
Indeed, indeed. And that's definitely one of the key goals, is to ensure that we shorten those wait times to provide care for patients in a timely fashion.
So I've heard some words of advice. You know, your primary care physician is really important, both regular checkups as your evidence around, and then maintaining that connection with your primary care physician. As we enter the last minute or so before we break, any last words of advice for any of you, from any of you?
I would really encourage patients to consider, or viewers to consider going to the Kidney Foundation of Canada website, where you can do a survey to see if you have risk factors for kidney disease, and then you could go to your family physician where they can do blood and urine tests to see how your kidneys are doing, because in the early stages of kidney disease often there are no symptoms, so it's important to be looking for it.
Great. Sandy?
No, I think that the main thing from our point of view is to listen to the patient and their family, and as Dave said, try to address their individual needs whenever possible.
And Ron, any advice?
I mean, the team at Credit Valley has been unbelievable. I mean, be it the doctors, the nurses in the home program, my prior nurses in the home peritoneal program, the pre-dialysis nurses, the dietitians, the social workers, the entire team, I know all of them by face and name, and they've all had a huge impact on how I've dealt with this illness.
So thanks for sharing your story and for providing us such valuable information. We're going to go into a break right now, and when we come back, we're going to talk about another chronic disease, and that's called chronic obstructive pulmonary disease. Stay tuned. Thanks. Hello, welcome back to Talk Trillium. This segment is around chronic disease, and it's my pleasure to introduce two guests today who are going to talk about chronic obstructive pulmonary disease, commonly known as COPD. Dr. Frank Ritacca, he's a respirologist and he's our division head for respirology at Trillium Health Partners, and Marni Wagner, who's an RN and educator for the COPD program at Trillium Health Partners. So welcome to both of you. I'll ask my first question. What is COPD, Dr. Ritacca?
Well, thanks for having me on today to speak about such an important topic. COPD is a chronic illness that is best characterized by at least partially irreversible obstruction to airflow. The typical symptoms that people would get would be breathlessness when they exert themselves. They often complain of chronic cough, inability to do things that they used to do, like exercise, or even in more severe cases, things around the home, like climbing upstairs, getting dressed. The disease is also characterized by frequent flare-ups or exacerbations, which often result in significant illness and hospitalizations.
So are there certain risk factors for developing COPD?
Well, by far and away, the majority of patients with COPD have been either previous or current smokers. In other parts of the world, pollution may play a role in the development, and in certain rare situations there are some genetic predispositions to COPD, and so all of those factors may play a role.
But by and large, it sounds like in our community, smoking would be the most relevant risk factor?
Absolutely. It's the first thing that we ask about when we see patients with this illness. It's the first thing we target in terms of our treatment if they are ongoing smokers. So by far and away, it's the most important risk factor.
So if I was a smoker, what would be some of the first early signs and symptoms that I might be developing chronic obstructive pulmonary disease?
Well, again, a lot of the times people who are either former smokers or current smokers often put aside their symptoms as just being related to being a smoker. So for example, I often hear people complain, well, I've had a smoker's cough for many years. Well, what does that really mean? Well, it means that there is something wrong with their lungs, that they have ongoing inflammation in their lungs that's leading to that cough, and often sputum production, and that might be one of the first signs of a problem. As I mentioned before, the other main factor, or the other main symptom that patients often have is that they find they can't do as much as they previously did. So maybe they have more trouble walking the golf course, maybe they have trouble climbing the stairs in their home, maybe they have some trouble getting dressed. And sometimes, not infrequently, the first time they find out about their condition is when they end up in hospital with a flare-up of their disease or with an infection that might be quite minor to most people, but for people with lung disease results in significant sickness and sometimes hospitalization.
So Marni, can you tell us a little bit more about some of the programs that we might have for patients who are diagnosed with COPD?
At Trillium Health Partners, we've got the 2 sites and 2 pulmonary rehab programs. I have an education program that is for any patients should you have had COPD, your doctor just told you you had COPD, or if you've landed up in the emergency department or the hospital with a flare-up, COPD patients would be coming to me.
Great. So when they come to you, what do you do?
So if you're new to having COPD, we're going to go, and or if you have COPD for years, we're going to go over the symptoms and what your specific symptoms are. So I see you one-on-one. Family is always welcome to come in. Go over the symptoms, the anatomy. The most important things that we have to look at too are, have you seen your doctor if you're just out of the hospital? Have you got your prescriptions filled? Are you using your medications properly? And for a lot of people, they don't understand how to use their medications or why. So we go over that. I also get into the topics of lifestyle. Smoking cessation is very important. I do have some of our family physicians sending them in for smoking cessation particularly, and they've had their breathing tests done and learning how to manage with the disease. We also talk about exercise, diet, and I can facilitate getting into the pulmonary rehab programs as well.
So the pulmonary rehab programs, can you explain a little bit more about what the rehab programs do?
Sure. What we find in people with COPD over the long term is that one of the main problems that limits people's exercise is chronic muscle weakness, and that often results from disuse. And people who have COPD often end up in sort of a cycle of inactivity that then leads to more weakness and increase in symptoms. So the rehab programs at both sites look to break that cycle, if you will, by teaching people how to manage with their symptoms, particularly the breathlessness, and to start to retrain those muscles that have been not used as much in the past. People who go through the pulmonary rehab program are usually in a program for about 10 weeks or so. They have an opportunity to continue with their exercises in the community after that program. The program meets about 3 times a week. Part of the program is educational, to what Marni was speaking about, medication usage, managing symptoms, managing some of the other symptoms of COPD that you may not think about, like anxiety and mood-related symptoms. And then most importantly, getting the patients to start exercising and moving. And when people finish the program, a lot of them will say that they have their life back, if you will. They're able to manage with their illness, not in a curative way, but in a way that allows them to do the things they wanted to do before.
So do you notice a difference, or do the patients have a difference in the amount of times they need to go to the emergency department, for instance, or see their family doctor once they're educated and they've been in a rehab program? Do you see that kind of difference for them?
Well, absolutely. I think there's a few reasons why that may be. Certainly, pulmonary rehab programs around the world have started to show that people who go through these exercise programs tend to have less usage of health resources, whether it be visits to their primary care physician, visits to the emergency department, admissions to hospital, etc. And part of that may be because the patients are better educated to self-manage their illness. Part of it may be that they have slightly easier access to either their primary care physician or their specialist physician to get them on treatment early if they're flaring up, and hopefully avoid the emergency room visits or prolonged hospitalizations.
So it sounds like the goal of both the rehab program and the education program is to allow patients to take control of their own illness and to be able to self-manage and to deal with some of the exacerbations that they might experience with their disease. Is that right?
That's right, yeah.
So Marni, you mentioned that sometimes patients are referred to you for smoking cessation. How challenging is that? Because I understand quitting smoking is one of the hardest things, one of the worst addictions, and one of the hardest things to do.
It is, and you know what? The important thing is to discuss the options. Many people that I see didn't know that there were options. How do I quit? How do I do it? How long do I take these medications for, or even the technique if you're using nicotine products? The prescriptions certainly from the family doctors, are they options, good options for quitting smoking? And then the other side of that, once they realize, oh gee, there is something that's going to work for me, is support. And that's where I offer that support. And I will book regular visits every 2 weeks 3 weeks, and it is weekly if they go on one of the oral prescription meds, just to monitor to make sure that there's no any side effects from those drugs. But
So-
it is challenging.
So what kind of success rates do you see? How successful are you in?
Pretty good. Pretty good. I have quite a few people that have actually called me on the phone. We had one intervention, and she said, after we talked, I didn't know, I got what I needed, and I haven't had a cigarette since. So that happens probably 50% of the time. The other 50%, we're still working on them, and they're still coming in.
That's great.
I think the first message is that people really need to be motivated to want to quit. It's very difficult to get patients to quit who are not ready at that stage. So there is quite a psychological process that people need to go through before they completely stop smoking. And some of the products that you're speaking of, be it nicotine replacement or other medications to help, are really geared towards the people that are ready to take that next step.
Right. And finding that step for them to take.
I know I've been through it myself, and I think some of us...
I have too.
Yes, and so we all know how challenging it is, but it's so worthwhile once we're free of the cigarette smoking. You mentioned it's important to continue exercising after your rehab program. Are there any places where you advise patients to register with, or do we have partnerships with the city at all?
We do. We have some partnerships that we've developed with community centers in the area that have allowed our patients to exercise in their centers at a lower cost, so that it's hopefully not prohibitive for many of our patients to get into a place where they could exercise. The other great benefit to the rehab program or exercise in general is really the camaraderie that the patients develop with each other. Seeing other people with the same illness, with perhaps the same limitations or disabilities, really helps to motivate them to do more, and when they see success with their colleagues, that pushes them to go further with their own exercise. So there's probably a big social aspect to the success of the rehab program as well that is difficult to measure, but is very clear when you speak to the patients.
And I think in our first segment, Dr. Morra talked about the importance of social network, and it's probably something that we don't think about very often, but it's so critical for patients and how they feel about their chronic disease, knowing that there's others like them and how they go through their illness. In the last minute, any last words of advice for patients who do have COPD?
Well, I think the first message is that if you don't have COPD and you're a smoker, then really work towards stopping smoking. If you have been diagnosed with COPD, the main message is that there is help out there for you. It's never too late to quit smoking. And the treatment that we have available consists both of non-pharmacologic treatments such as rehab, education, and exercise, as well as medications and vaccines, which are all very important for keeping you healthy.
Well, thank you so much, both of you, for joining us today. We learned a lot about COPD, and stay tuned because our next segment is going to be around diabetes. So thanks for joining us. Thank you so much. Welcome back to Talk Trillium. Today we've been talking about chronic disease. I'd like to welcome my three guests today. Stacey Horodezny, who's the manager for diabetes and has been the guru in diabetes across Canada for about 20 years now. Dr. David Dane is our medical director of primary care for Trillium Health Partners and has been involved in almost everything, I think, related to chronic disease and more. And Marilyn Peters, who's a nurse practitioner with our seniors program. So welcome all of you.
Thank you.
First question would be for Stacey. So what is diabetes and what kind of prevalence is there in our community with diabetes?
So we see it every day, Patty, in our clinic at the hospital, and we see the increase in the volume of people with diabetes in our community. And the 2011 Peel Public Health statistics say that we have about 125,000 people living in Peel region with diabetes. We have an average of about 8,500 new cases diagnosed every year. And in the next 10 years, we are going to expect over 90,000 new cases of diabetes in the Peel region.
So diabetes is everywhere in this region. What are some of the risk factors for diabetes?
So there's a number of risk factors for type 2 diabetes. I'm going to focus on type 2 diabetes.
What is type 2 diabetes?
So type 2 diabetes is, it's a problem with your insulin that you produce from your pancreas. So when you eat food, a lot of the food that you eat gets digested into glucose or sugar and gets entered into your bloodstream. And as your blood sugar starts to rise up, insulin is responsible for taking the glucose or sugar out of the bloodstream and bringing it to the cells of the body where it's needed. And that happens in every single person around the world, and that's what our normal body does. When you have diabetes, the insulin isn't working properly. There's not enough, it's not working. So what happens is you end up with a rise of sugar in your bloodstream. So when you go to your family doctor, like David, he'll do a simple blood test, and lo and behold, he'll say your blood sugar is high and now you have type 2 diabetes usually. Type 2 diabetes is the most prevalent kind of diabetes across the country. It accounts for over 90% of our cases.
And so the risk factors for getting diabetes and for other chronic diseases, David, what do you see?
We see in my practice and across our family health team the same things on a smaller scale that Stacey sees, rising amounts of diabetes. And the risk factors are numerous. We're all aware that unhealthy diet and being overweight is a risk factor for type 2 diabetes. Family history is also another significant risk factor. And sedentary lifestyle also puts one at higher risk for diabetes. And we certainly are seeing a lot of diabetes in our team. And in fact, we're seeing so much diabetes, we're looking at new ways within our practice to handle the large volumes of diabetics. The complicated patients often end up in Stacey's program, but the more simple or straightforward diabetics, we're starting to do innovative things in our practice involving group visits where we bring groups of diabetics together and try to share experiences around their diabetes and co-manage them all together. And I think our patients have really enjoyed that, and we've seen good outcomes from that.
You know, from the beginning of the show, we started talking about chronic disease in general, then we focused on chronic kidney disease, chronic obstructive pulmonary disease, and now diabetes. And every single segment has talked about the importance of primary care. So David, in general, you must be seeing more people with chronic disease in general. And what does that mean for your practice?
Well, it's true, Patty. We are seeing a large rise in patients with chronic diseases, not just diabetes, but many chronic diseases. You mentioned chronic kidney disease. We see lots of patients with chronic heart disease, chronic lung disease, chronic mental health issues, and it is changing the nature of primary care. Like many parts of the healthcare system used to be all about acute illnesses and acute injuries, and we designed the system to support that. Now we're having to go back and redesign the system from primary care all the way up through acute care and long-term care in terms of chronic disease management. And what that means, it means a focus on not just coming in when you're sick, but doing things ahead of time to make sure that you don't get sick, so you don't end up in the hospital with a flare-up of your chronic disease. So we're starting to see now the requirement to call patients in on a more regular basis for our diabetics, for example, or for our heart failure patients, so that we can stay ahead of things, so that we can make sure that the recommended processes around managing chronic disease are happening before people are in trouble and landing up in the inpatient units at Trillium.
Mary Lynn Peters, you see seniors, I think both in a clinic and in their home setting. As a nurse practitioner, what are you seeing the impact of chronic disease on our seniors population?
What happens as we get older is that we tend to have more than just one chronic disease, as opposed to a younger person who may have started initially with diabetes. As we age, then we also then find that there are kidney problems, then there may also be heart problems, and unfortunately cognitive changes are very prevalent as we age. And so what happens then is that our older patients are dealing with multiple comorbid or chronic illnesses and trying to figure their way through all of these complex regimens and treatment plans. And I find that that causes frailty and a greater need for services and more comprehensive, intensive services for our older persons.
Stacey, is there something we can do to prevent diabetes from happening or keeping it away?
I think one of the biggest challenges is for people to really understand their risk. Do they have the family history? Are they overweight? Do they have diabetes in their mom, their brother, somebody out there? And then really looking at trying to live that healthy lifestyle. So it's about trying to eat as healthy as you can and exercise. I think exercise is probably one of the easiest things that we can all probably encourage all of our clients to do. And it is a challenge, especially given
Easier
certain
said
times
than
of
done,
the year.
I think.
It is. Well, one of the unique programs that we have at our Diabetes Center is we have a Sweet Success exercise program. We have partnered with Huron Park through the City of Mississauga and Parks and Rec, and we actually offer exercise programs at Huron Park for our patients with diabetes, and the results have been phenomenal. In fact, the people who go off and join that program never come back and see us because they're doing so well. So looking at opportunities for people to work together, because often it is hard. You come home after a long day or the weather's not very good and you just don't have a lot of impetus to go out and do some new exercise. But looking for other people who are like yourself can really help support each other and do more exercise.
It seems like eating well and being physically fit is the key to reducing chronic disease for all chronic diseases, because we've heard the same advice for COPD, for chronic kidney, now for with diabetes. But the other piece of advice that we heard from Dr. Morra was to have a family doctor. So David, I understand that a third of patients living in this community don't have a primary care physician. Is that true, and how could one go about getting one?
Well, having a family doctor is important for your health, absolutely. I have a bias in terms of saying that, but I do feel very strongly. It's important to have someone who knows your entire story, not just your heart story and not just your lung story, but your whole story, your family story. And so having a family physician I think is important in general, and particularly becomes important as you get one or multiple chronic illnesses. In terms of obtaining family physicians, our community is, I think, doing better than that number. I think that number is probably more likely a provincial average. But there are still folks who are struggling to find family docs, and there are both provincial and local ways to find a family physician if you're having challenges. Healthcare Connect is a Ministry of Health initiative that links people searching for family physicians with family physicians who are accepting patients, and as well, our hospital keeps a list of physicians who are actively accepting patients, and so those are two ways that you can work on getting a family physician if you need one.
So I want to move now into a discussion around something called Health Links, and Health Links was a proposal introduced by the Ministry of Health provincially. I know that we are one of the first Health Links up and running, but it was recognizing that 5% of the patient population consumes 66% of the healthcare resources, and those are the 5% of patients who have multiple chronic diseases, and trying to, I think, find a way of better managing the chronic disease. David, I understand you're one of the leads for the Health Links in partnership with Trillium Health Partners and the Somerville Family Health Team. Tell us a little bit more about that experience and what you've discovered through that.
Working on the HealthLink project has been a very, very exciting activity for me. We've been working on this for about 2 years now, and you're correct. The specific population that we're looking at in HealthLinks is those patients who have multiple chronic illnesses simultaneously and very often have challenges in terms of the social part of their story. So it turns out that those 5% who consume a fair amount of the spend that you're referring to, often it's not just their medical problems that make them use services in a large extent. It's often because there are other things associated with their situation that make it difficult for them to access the care. So there may be folks who have poverty as part of their story. It may be transportation. It may be mental health or an addiction problem. And when you add those things together with several chronic illnesses of the type that we've been discussing, it's a huge challenge for those folks to be able to manage their care. And as a result, because of the way our system is sometimes a little bit too disconnected, those patients who have the social problems and the medical problems together fall through the cracks in our system and end up in the emergency department and being admitted unnecessarily. HealthLinks is about bringing all the the folks involved in their care together in a more organized way and collaborating around a plan that's not just the hospital plan and not just the family doctor plan, but it's the plan for all the service providers to work together in concert with that patient and their family. And the really exciting thing about that plan that I'm talking about is that the patient drives what that plan is about. That plan starts with, what are the goals that you want to achieve as a patient with these challenges? Is it that you want to stay out of hospital? Is it your goal, I want to get to my daughter's wedding? Is it, I'd like to be able to play more with my grandchildren and not feel so short of breath? And we start with those goals, not just the medical problems. And then we say, well, what can we do to support those patients, both from a physical health point of view, a mental health point of view, and from that social side, to bring all the right providers together with a common plan in order to get people healthier and staying out of hospitals, which I think is pretty much everyone's preference.
That's really refreshing. It's all about the patient's goals and the patient's expectations in care, and that's really driving that. Mary Lynn, in terms of seniors with chronic disease, any last words of wisdom for families out there?
I would echo what has been previously said about healthy lifestyle choices. We do know that that's very important for heart health, kidney health, but also for brain health. And all of those things will help an older person to be functional and safe in their home environment as long as possible. And having, as Dr. Dane was saying, that one captain of your football team who knows your whole story and can pull all the pieces together is the important part for older persons.
Well, thanks for joining us today, and thank you for joining us today. Our episode was on chronic disease. For more information, you can look at our website, www.trilliumhealthpartners.ca, and see you next time. Thank you.